I'm just going to speak from my heart and about the work that I've been doing in research and PSA testing and active surveillance. And feel free to chime in if you have questions. And Daryl, you just do time out when the time is over. Sometimes I talk too much. But where did it all start? Why am I here? I ask myself the same thing too sometimes. Why am I in New York when I could be home in beautiful Sweden? And I think I'm... Yes, that's what Greta said too. Greta, she's amazing. She's our role model. But I guess I'm here for the same reason as Greta. I guess I have a mission and something to accomplish, and that's why I came here. I was offered a research position at Memorial Sloan Kettering because I wanted to help you. I wanted to help you not only live longer but also live better life. So not only improving longevity with screening and early detection, but also letting you have better lives and preserve the quality of life with active surveillance and improving outcomes for men who have prostate cancer and undergone treatment. So I was a med student in, 15 years ago in Sweden. And I was in this surgery or urology ward. And I remember seeing this patient in this ward bed. And we would do the rounds and he would just, he wouldn't talk. He would just moan and be in excruciating pain from bone metastases from prostate cancer. And that was my first view of a patient with this disease. So I was wondering, is there something we can do? Could we have prevented this? Could we have done something earlier? And I would get an envelope from the Swedish government to go and get screening for cervical cancer screening. My mom would get an envelope to get mammography screening, so breast cancer screening. But why didn't my dad get an envelope to get PSA testing? So that's how I got interested in screening and early detection, because I wanted to find out, I was like the curious child. I wanted to find out, why is it that we don't have PSA screening on a population level in Sweden? Because in Sweden, it's even more common than here in the US. So the lifetime risk of dying is 5% for a man. Here in the US, it's about 3%. So Swedes are like the African Americans of Europe. So Swedish men have a very high risk of prostate cancer. So I was wondering, why don't we do something? What is the evidence? And then the more I started reading, the more I realized this is not just preventing cancer and finding it early and reducing your risk of dying, but there's also these nuances with anxiety and false positives and overdiagnosis and overtreatment. And I got so interested and fascinated by prostate cancer that I wanted to continue to work in this field. And luckily, the professor in Sweden that I work with had started a trial. And I became a member of this trial, the European randomized study of screening for prostate cancer. And we embarked on this journey together, and now it's been over 20 years. And that study, which was a large European study with 160,000 men, have now shown that regular PSA testing of men between ages 50 and 70 reduces prostate cancer mortality by 20%. So there is really an advantage with early testing in finding the cancer early, treating it, and then reducing your risk of developing metastases and mortality. And what's interesting in this trial was that a quarter of those men were untreated, and we still saw this benefit. And in Sweden and in Scandinavia in general, we've had a more conservative approach to prostate cancer. We have, sort of been more hands-off, and active surveillance was we already embraced this early on. And then I came here to the US, and here you treated everything. You would do surgery or radiation, cut it out. So over the past 2 decades or so, most men would have surgery or radiation. The rate of active surveillance was only 10%. But now in recent years, we've seen an uptick in active surveillance for low-risk prostate cancer. So it's about 50% of men now. At Memorial Sloan Kettering, where I work, about 90% of men with low-risk prostate cancer choose active surveillance as their first option. So it's really a change in the treatment paradigm that we see. And the idea behind active surveillance is that you can postpone the side effects from not undergoing treatment as long as possible. And the emphasis is really on the word active. So it's not doing nothing, but we still monitor you closely. So we will do, at Memorial Sloan Kettering, the program is we do a PSA and a digital rectal exam every 6 months. And then we do an MRI every 18 months, and then we'll do a prostate biopsy every 3 years. We can also do it earlier if we see signs of progression. So, for example, if the PSA keeps rising or we see something on the MRI. If patients come to us at MSK, we also look at if you've had an MRI from the outside, if you've had a biopsy before. We retrieve all this information and we will review it ourselves. But we also do our own MRI and our own biopsy to confirm the diagnosis at the start to make sure that we haven't missed anything. So it's important to have a comprehensive risk assessment at the start of active surveillance. So we've really seen a change in the treatment. And Dr. Peter Scardino, who was the former chairman of surgery at Sloan Kettering, he says the right treatment for the right cancer in the right patient at the right time. So it's really, prostate cancer treatment is really about risk assessment. And who is a candidate for active surveillance? Well, it depends on the risk. If someone has prostate cancer that's of intermediate or high risk, then we recommend some sort of treatment generally. But if a patient has low risk prostate cancer, most of those men are eligible for active surveillance. And low risk means Gleason score 6, so 3 + 3 = 6, or today we would call this grade group 1. Usually low volume of disease, but sometimes you can have higher volume also of the disease. Usually the PSA is low, less than 10, and the T stage is T1 or T2 generally. There are some men who have intermediate risk, so Gleason score 3 + 4 = 7, and small volume of 3 + 4. Some of those men could be candidates for active surveillance also for a short period or for a time until we see signs of progression. And in our experience, we have about 3,000 men who have gone on active surveillance at Memorial Sloan Kettering, and half of those have not yet undergone treatment over 10 years or so. So that means that, like Dr. Cheetham was saying, for most patients, they remain on active surveillance for a long time. And then as you get older, sometimes active surveillance become watchful waiting, because then your life expectancy is shorter, and then you might have other diseases or illnesses that might interfere. So it's really, we follow these patients a long time usually. And the long-term outcomes are good. Yes, active surveillance is a safe program for carefully selected patients who are also carefully monitored. So the studies, there was one study in the UK that compared active surveillance to surgery and radiation, and it did not show any difference in survival between the three groups for men who had low-risk cancer. So we should not be treating low-risk cancer aggressively, but monitoring is, according to most guidelines today, the preferred option or the best available care option for men with low-risk cancer. So it's usually our first starting point. We talked about anxiety, and it's very normal to be anxious because you have a cancer diagnosis. Just the word in and of itself may, could get anyone to have a panic attack. And it's normal to have the feeling that you want to get rid of it, you want to cut it out, you want it out of your body. And it's also normal to face pressure from your loved ones or your family or your friends or even your doctor to treat it. So are you a candidate for active surveillance? Yes, if you have low-risk cancer, so your biology is at low risk of progressing, but also if you can sort of handle your surroundings. So are you prepared to have a conversation with those who might, sort of pressure you to do something? Are you comfortable with talking about prostate cancer with your family? And what are some of the questions that they may raise? It's important to think about. And if you feel overly anxious, there is counseling and support. So we have, at Memorial, we have a counseling service in the Department of Behavioral Sciences and Psychology, excellent clinicians and social work. Dr. Dyer Mitteldorf knows about the importance of support groups. We also offer support groups. I work with Dr. Befare Day, who's leading our active surveillance programs, and we are now offering what's called a shared medical appointment, where men who are on active surveillance come together for their medical appointment, but in a group setting. So it's still a meeting with the clinician, but they also get to meet peers or patients who are in the same shoes or who have been on active surveillance for, a long period of time, short period of time, and they can learn from each other. And we talk about their symptoms, and they're very happy to share their experiences in front of others in the group, and they can all benefit from listening to the others' stories. So that's a new program that we have started for active surveillance as our program is growing rapidly. And like I said, anxiety. Surgery is not the treatment for anxiety. Radiation therapy is not either. So there is a way of dealing with your emotions. And like Dr. Cheetham was saying, usually, and also in our experience, anxiety decreases with time. So 2 years after active surveillance, patients feel more safe and secure in the program and sort of have cognitively reframed living with the cancer diagnosis. Because if you choose surgery just because you want to get rid of it, you have to remember that surgery is very skill dependent. So, the robot it's not the robot who's doing it, but it is who's doing the robot. So if you are considering surgery or brachytherapy or something else, ask your provider, how many have you done and what are your outcomes? That person might say, I've done 3,000, but quote, some general outcomes from the literature. But if they're don't know their own outcomes, how are they going to improve? So it's very important to know, whose hands you're placing your life, into, because you will then have to, deal with the consequences of the surgery. So active surveillance allows you to preserve your function, your sexual function, erectile function, your urinary function for as long as possible until we see some signs of progression. And then treatment is still an option over time. So it's not like watchful waiting, or it's not, doing nothing and you come back when you have bone mets or you can't pee. But we still monitor you within the window of curability. So if we see a change in your tumor, if the tumor is still, we see it's growing, or we see an increase in volume, we see an increase in Gleason grade, there is still an opportunity for curative treatment. And that's how active surveillance is different from watchful waiting. So watchful waiting is more a strategy for men who have a short life expectancy, where we would do palliation on signs of symptoms. But with active surveillance is still, postponing the time to treatment, but you still have the opportunity to get cured once treated. So yes, active surveillance is definitely on the rise. It's a combination of your cancer risk and the side effects of treatment and your overall health that determines if you are a good candidate for surveillance. But cure is definitely possible when it's necessary, and cure is not necessary when it's possible in all cases. So that's why active surveillance comes in as an option. Thank you.
I think also, before you run away, Dr. Carlson, you may just want to say a few words about active surveillance and the role of the genomic testing like Oncologist. So if you take 100 men with low-grade, low-risk prostate cancer, they don't all behave the same. So Mr. Average is Mr. Average, but some cancers will behave much better than average, and some will behave really, really good. And then there's others at the end of the spectrum who eventually these cancers may progress. So there are tests now that we can use in association with active surveillance that can help us determine who have these kind of cancers. Not that it's a big panic, but ultimately may need treatment. And then there are other patients who have favourable molecular scores that support the decision that active surveillance is a good option. And one thing, before I hand the microphone back, patients always worry, well, if my disease progresses, am I going to miss the boat for cure? And I think it's very important to emphasise that even aggressive prostate cancers do not explode overnight. So if you're on active surveillance, and again, it's about getting the right patient in at the beginning. So patients with Gleason 8, 9, 10 prostate cancer are not ideal, should not be on active surveillance at all. So it's about being selected appropriately from the start. But if you're appropriately selected, and in fact, Jonathan Epstein, who's a pathologist who specialises in prostate cancer, defined what's called the Epstein criteria. And he said, and this was pre-MRI, so it's historical, but the ideal candidate for active surveillance is Gleason 6 only, 2 cores or less positive for prostate cancer, and any one core should have less than 50% core involvement. The problem is now we're much better at targeting the cancer. So his criteria were defined pre-targeted MRI. So if you know where the cancer is, you're more likely to have a higher percentage core. So we have to take that into consideration. But we now have much better MRI imaging to guide surveillance. But I think the point that I want to make for patients, if active surveillance is an option for you and you're appropriately selected, you do not need to worry that all of a sudden your cancer is going to explode overnight and you're going to miss the boat. The only way that you come to harm, if you're appropriately selected for active surveillance, the only way you come to harm and miss the boat is if it's not active and it's not surveillance. So if you choose active surveillance, it's no good if you come in once every 2 years for a PSA. You've got to be followed up. But for those patients that do, and again, the patient who's poorly compliant is not a good candidate for active surveillance. But those who do, it's very rare for them to be taken off. So I'll just let Dr. Carlson say a few words about the genomic testing, because I think it'd be helpful to address that.
Thank you. Yeah, those are really good points. There is usually no rush with the decision if you have low-risk disease. And like you said, Gleason score, or the grade group system, and what the cancer looks like under the microscope is today the most predictive factor we have that determines the prognosis of prostate cancer. And now with the MRI and the imaging, we can also better see the cancer in the prostate. Because back in the days, it might be that we might have missed tumors that were anteriorly in the prostate, but now we can visualize them with the MRI. So it's really important to do a comprehensive risk assessment at the start of active surveillance to ensure that you are a candidate and they confirm the diagnosis properly so we haven't missed anything. And having high volume of Gleason score 6 is a risk factor for having higher grade cancer somewhere else in the prostate. So that's why we tend to put men with lower volume on active surveillance, but it's not an absolute criterion. So low-risk cancer and Gleason score is usually what we use the most to determine eligibility. But then we can use the molecular markers in cases where we are sort of at the cusp of should you treat or not treat. So someone with a low risk 3+4 or Gleason score 7 or grade group 2, where we are not sure should they do active surveillance or should we go on to active treatment with surgery or radiation. If then the genetic score shows or indicates a higher risk, that could be sort of another factor that adds to the equation of the management. But we don't use those markers on everyone because they're also expensive, and as you know, the insurance companies might not always pay for them. So the classic criteria with the Gleason score, the MRI, the PSA, and what the prostate feels like are usually good indicators enough to make the decision initially.
Thank you very much. And for those of you who do want to get more information about the molecular markers, this is done on your biopsy tissue. So you don't need to go through another biopsy to get the genetic markers done. So it's always worth asking if active surveillance is on the cards. Ask about whether your biopsy has been sent for either Oncotype DX or Prolaris, because that score can be extremely helpful in giving the sort of support that active surveillance is a good idea, or if you have an unfavourable score, then we may talk about sort of treatment options down the line.